Good morning, everyone. Respected teachers, chairpersons, and all the cardiologists. I am Dr. Abhishek Samdesi. I am a final year DM cardiology resident from Saptagiri Institute of Medical Sciences. I would first likely to thank everyone as well as the Women's Cardiac Care for providing me this opportunity to present a simple, humble case in front of you. The topic is a dynamic enigma, rate-dependent left bundle branch block. So coming to the case presentation, a 50-year-old female, she was referred from ENT department for cardiac fitness for surgery. She was a newly diagnosed case of hypothyroidism. Her ECG showed a sinus rhythm with a heart rate of 80 beats per minute, regular and inverted T waves seen in 1 AVL, 2 AVF and from V4 to V6. Her echo was normal. So this is the baseline ECG where we see that there is inverted T waves from V4 to V6, even in 2 AVF, 1 AVL. In view of the ECG changes, the patient was advised to undergo a TMT. So the patient underwent TMT, but during stage 2, at around 6 minutes with a heart rate at 145, there was a transition from sinus rhythm to left bundle branch block as noted in this particular TMT strip. Later on, the patient developed chest pain at around 6 minutes 53 seconds and the TMT was terminated. On recovery, at around 3 minutes, the patient LPBB reverted back to the normal sinus rhythm. But even at recovery, the patient had ST depression with inverted T waves seen in the inferior and the lateral leads at 2-3 AVF and V5 to V6. In view of chest pain and the ECG changes even at rest, the patient was advised to undergo coronary angiogram. So this was the TMT report. Patient developed rate-dependent left bundle branch block in Bruce stage 2 at a heart rate of 145 beats per minute at 6 minutes of exercise. The exercise was terminated in view of chest pain at 6 minutes 53 seconds. LBBB reverted after 3 minutes into recovery phase. She had a normal heart rate and BP response, and there was good exercise capacity at 8 minutes. So the patient underwent angiogram, and angiogram showed the proximal to mid long segment lesion in the LAD maximum 90%. In LCX, it showed ostial 20 to 30% stenosis and proximal to distal long segment 90% lesion. The patient underwent PTCA stenting to LAD as well as LCX, and TIMI-3 flow was achieved. Coming to the discussion part, left bundle branch has dual blood supply by both LAD and PDA. We call it rate-dependent LBBB when there is a transient left bundle branch block associated with an increase in heart rate. But sometimes it can occur spontaneously without exercise at any heart rate. Whereas exercise-induced LBBB is a variant of LBBB due to increased heart rate which is elicited during exercise testing. The rate-dependent LBBB is a rare electrographic occurrence that may be detected during exercise testing with an incidence of around 0.4 to 0.5%. The rate-dependent LBBB is an independent predictor for major cardiovascular morbidity and mortality. There are few proposed mechanisms for the transient bundle branch block, such as physiological block during phase 3 and 4 of action potential, acceleration-dependent block due to disease of the His-Purkinje system, or because of a concept called as retrograde concealment, where there is retrograde penetration of the bundle branch renders it refractory to subsequent stimulation. Coming to the prognostic significance, rate-dependent LBBB predicts higher risk of death in 29% and major cardiac events in about 19% of cases. Exercise-induced LBBB at a heart rate of less than 120 to 125 beats per minute correlated with occurrence of occlusive coronary artery disease, whereas a heart rate of more than 120 to 125 usually have normal coronaries and a better prognosis. Exercise-induced LBBB is associated with coronary artery disease in 70% of the patient, whereas exercise-induced RBBB is associated with coronary artery disease in 100% patients. So the take-home message is patients with this uh, rate-dependent LBBB is usually considered as benign, but its presence is associated with higher all-cause mortality rates. Occurrence of rate-dependent LBBB during TMT may be a direct evidence for ischemia as seen in our case. Thus, patient developing exercise-induced LBBB on exercise stress test should be evaluated for any underlying coronary artery disease. Thank you, ma'am.
Good. What was the indication of stress test in this patient?
Ma'am, because of the baseline ECG changes, ma'am, where they were
What was
inverted.
the baseline ECG changes?
This one, ma'am.
Patient was asymptomatic, no
Patient was
exertional
completely
symptoms.
asymptomatic, ma'am. But she presented with this baseline ECG where. Can you project? There were inverted T waves seen in the inferior lateral leads, ma'am. One AVL to AVF as well as V4 to V6,
Yeah,
ma'am.
because ECG itself looked
Yes,
like
ma'am.
a LED profile.
Yes, ma'am.
ECG, yeah. So such cases to do a stress test is again challenging. And regarding the heart rate and the correlation of LBBP,
Yes, ma'am.
sometimes unconditioned heart also, so that is not the marker because their heart rate immediately accelerates.
Yes, ma'am.
Those who are unconditional activities and all. Second thing is all rate dependent LBBP, would you recommend coronary angiography?
No, ma'am. Especially in this
So
particular.
how will you decide?
Yes, ma'am. In this particular patient, there was
This
chest
case
pain, ma'am.
is okay because even
Yes,
the
ma'am.
baseline ECG reflects and the so not only the ECG is the marker but the chest pain,
Yes,
the
ma'am.
comorbidity, they are the indicators of performing a coronary workup. Good.
So just one more question. So any female who comes to me with STT changes and asymptomatic plus minus atypical symptoms, I prefer to go for exercise stress echo
Okay, ma'am.
rather than, stress test because stress echo gives you more information.
ma'am.
So in this case, if you had done a stress echo, you would have seen definitely regional wall motion abnormality. That would have been more specific.
Thank you very much, ma'am.